Okay, welcome everybody to another fabulous episode of COPD Navigator Live. This week we've got a great episode for many people. We're going to be covering the basics of COPD medications, which can be very confusing and are very widespread, and just about everybody is on one. My name is Mike Hess. I'm a respiratory therapist and COPD educator. I also run a group here on Facebook called COPD Navigator, and we do these live shows every Friday to answer questions and get some information out there to help people manage their COPD better, and to give them the information they need to go back to their providers and ask the right questions and make sure that you're getting the best care possible. You can find our group here, as I said, on Facebook at facebook.com/groups/COPD Navigator. For the month of November, which is COPD Awareness Month, the COPD Foundation has been gracious enough to help me boost my signal here with by providing these episodes through their Facebook page. So many thanks to the COPD Foundation. I am also a COPD Foundation State Advocacy Captain, and if that's something you're interested in doing, I highly recommend it. It's a great program to bring awareness about COPD issues to the larger community of people who don't necessarily know about COPD. So, generally speaking, we start these episodes with a brief look at what's new in the world of COPD, COPD news kind of segment. This week, there's not a lot going on clinically, but there are some cool things happening as far as advocacy and all that kind of stuff. First and foremost, I got in the mail today brand new COPD awareness t-shirt that the foundation has been doing as a fundraiser for the last couple of weeks. This was part of the round one fundraiser effort for the COPD Foundation, and got our t-shirt today. The fundraiser is still available, and let me copy and paste the link here. If you are interested in getting your own orange t-shirt. Orange is, of course, the advocacy color for COPD, and for trying to raise some money for various other initiatives for the COPD Foundation. You can go to that website down there, customink.com, and sign up to the t-shirts are $15, and you can get yours on its way. In addition, we've got a lot of stuff coming up next week, actually. November 15th is World COPD Day, a day where the entire world kind of comes together to get better information out there for COPD and to raise awareness and to make sure everybody understands what it's like to live with this kind of disease. And the COPD Foundation, again, has several different initiatives to help encourage that along. First off is a briefing that the foundation is holding with several other organizations for legislators to try and raise awareness in the legislative zone about the issues that many people who live with COPD face, including access to things like pulmonary rehab and even affordable medications, to try to bring these priorities to more of the forefront of legislators' minds so that we can get some improved efforts on that front. So this link that we've posted here, the COPD Action Center, that's a link that you can click on, and it's pretty much one-stop shopping. There's a pre-designed template where you can enter your address and sometimes a phone number if your legislator happens to require that, and send some information to encourage them to attend this event in Washington, D.C. Next week for COPD World COPD Day. In addition, on the patient end of things, the COPD Foundation is putting forward an event called Living Well, Staying Well, The Faces of COPD. This is, again, a free internet-based event which will be taking place November 15th, again, next Wednesday, from 11 a.m. to noon Eastern Time. There's going to be a great array of, there are two patients and a respiratory therapist who works for the foundation, who will be giving their tips on living well with COPD, talking about their own individual journeys, and helping people connect with the Foundation social media site, COPD360social.org, a group of more than 32,000 patients, caregivers, respiratory therapists, friends of the COPD community, other healthcare professionals, all kinds of stuff. So that is a great event. And let's see, we got a link up there. We've got a link right there. So that you can go to this website that just got linked underneath the video here and register for that. So that's kind of the big news with COPD upcoming right now. There's a lot of stuff that's in the pipe, especially for next week as we get into the meat of COPD Awareness Month and try to pull things together here. As I said, we're going to be talking a lot about medications today. If you're not familiar with the COPD Navigator live program, what we do is we talk, usually have about a half hour or so of a pre-designed lesson plan, so to speak, where we talk about a particular topic of the day, and then after that is questions and answers, which I see some people are putting in there already. I encourage everybody to put your questions in there. We've got some time after the event here. I'll definitely answer questions. Doesn't have to be about medications. It can be about whatever happens to be on your mind. Hopefully we'll cover some of that stuff as we go through the process here, the episode, and then we'll get to the remaining questions at the end. One thing I do want to address is there's one comment already that says nothing can help this stuff, it's a death sentence. And while it's true there's no cure and there's not necessarily an effective treatment to improve it, there are definitely ways that we can help people manage their symptoms better and try to help them live their best life. I will not deny that as a healthcare system, we do often drop the ball on that, and that's why it's so important to recognize initiatives like COPD Awareness Month and a lot of the other projects that the Foundation is involved with, and a lot of other clinicians around the country who are really, we're working hard to try to change that paradigm, because for a very long time it has been kind of this disease that gets swept under the rug. And I don't think that's acceptable, and I'm sure many of you watching today don't find that to be acceptable either. And so we really, I'm hoping that we can all kind of band together and really start making some changes about this. There are some great initiatives going on right now, most notably the COPD National Action Plan, which you can look at copd.nih.gov, which for the first time offers a national template for how we're going to be starting to attack some of the issues surrounding COPD care, including, as I said, access to things like pulmonary rehab, to medications and all that kind of stuff, so that people who don't necessarily have insurance or who don't have access to see a specialist, we want to still be able to improve your quality of life. As Dr. Thomashaw, who is the chair of the board of directors of the COPD Foundation, said when the National Action Plan was unveiled, this disease, COPD, has to live in primary care. And it's absolutely true that we have not done a great job supporting our primary care providers and clinicians in that realm to manage this effectively, and that has trickled down to people not being managed effectively. But I promise you, we are working to change that every day. As far as what best inhalers are going to get, we're going to dive into that right now, as a matter of fact. Because there are a lot of different inhalers out there, and what is best for one person isn't necessarily best for the next person. So we've got to take a look at two of the main concepts we have when we're talking about COPD medications. Is there are really two very broad categories of these medications. The first off is called a controller medication. These are medications that you would take every day, whether you're feeling good, feeling bad, feeling indifferent, to try to help keep your baseline symptoms at a relatively low level. These are things like excuse me, Spiriva, Tudorza, Asmanex is sometimes considered a controller, Advair. A lot of these medications are basically long-term medications that as you take once to twice a day, and to keep things in check. If you have a bad symptom day, you go to the other class or the other type of inhaler called a rescue medication. These are things like albuterol, which probably just about everybody out there watching is familiar with. And these are things that work very quickly to kind of open up your airways and get things back under control when you have some of those symptom flares. Now, this is kind of the part where it gets a little bit technical, and where I try to work very hard to teach people the language, teach people the vocabulary of COPD and medications, so that when you go back to your provider, you can say, why am I not on this medication, or why am I getting this instead of that, and so on and so forth. Medications like albuterol are what are called beta agonists. They work in a particular chemical path inside of your lungs. We don't really need to dive deep into the physiology or the chemistry, but suffice it to say, there are a couple different chemical paths inside your lungs, and albuterol and medications like it work to on that chemical path to open up your airways and help you breathe a little bit easier. These medications they come in short-acting forms like albuterol, and they come in long-acting forms like salmeterol or Ceravent, which some of you may have seen before. Some of the newer meds like Straverdi, those are coming out here, and these are what we call beta agonists. Some of these, like Ellipta, Ceravent, and Straverdi, these are your long-term medications. Again, you're taking them on a controller basis, and taking them every day to try to keep your symptoms at a relatively low baseline. These medications, we started using these medications in the COPD world because we found they worked pretty well in the asthma population, and that's where a lot of our COPD treatments have originated. Get into a whole bunch of other meds, so if I haven't come across one that you're familiar with, then just bear with me for a couple of minutes here, and I promise we'll get to that. While these beta agonists have been a mainstay of care for a very long time, we found to a certain degree that there's another type of medication that works on one of the other chemical pathways inside of your lungs that oftentimes works a little bit better in the COPD population. And these are medications now that GOLD, the Global Initiative for Chronic Obstructive Lung Disease, is saying they're a little bit wishy-washy on it, but they're saying there's a slight preference for these medications called LAMAs, or long-acting muscarinic antagonists. So you might hear these phrases LAMA and LABA and stuff like that thrown around, especially when you're talking to your clinician, because we medical people do like our acronyms and we like our buzzwords and all that kind of stuff. So these anticholinergics or LAMAs or what have you, these are things like many of you hopefully may be familiar with things like Spiriva, either in the HandiHaler format or the Respimat format. It's been around for quite a while and has been a very solid frontline medication for us. Incruz is another one. Tudorza, these are relatively new on the market, but again, these are controller medications that work to keep things under control on a daily basis. And the third type the third chemical type of medication that we use are what are called inhaled corticosteroids, or ICS, or simply steroids for short. And these are medications that don't necessarily work to relax the muscles of the airway or to open them up that way. These are things that also came out of asthma therapy to help bring down the inflammation or the swelling and that sort of thing involved with lung disease. They have been one of our frontline medications for a very long time because they are pretty effective. But we are seeing that there are certain circumstances where they can increase your risk for things like pneumonia. We're not entirely sure what that trigger is, but we're also seeing that it can be appropriate in sometimes where if somebody is on inhaled steroid, which is fairly common, we can kind of step down that therapy without the risk of increasing symptoms. And so basically what we see here is we use these three types of and I should clarify, these are medications like Asmanex, Qvar, Flovent, various brand names. I should point out that I am not affiliated with any of these companies, and so when I mention a name, it's not necessarily an endorsement or anything like that, just simply throwing them out there as fairly common ones that people may experience. These medications work, again, pretty well, but they do have certain risks with them, and we have to keep that in mind. Now, what a lot of people are on, because we want to manage one or more of these chemical pathways at one time, we often have combination therapy or even triple therapy where we're using all three of these at the same time. And that's where some of these medications like Brio, which has been asked about, Symbicort, Advair, some of these medications come into play. These are mixtures of two different medications in the same inhaler. Again, it makes it a lot easier for dosing. This is where you can just take these medications once or twice a day and you're getting kind of a double hit, sort of a belt and suspenders approach. And they work to keep those symptoms under control. There are some disadvantages to that kind of therapy. Again, we have seen that when you have these long-acting beta agonists, the long-acting albuterol type of drugs, a lot of times it's difficult to get those without having the inhaled steroid component to it. So it can be a little bit tricky to find the right combination of medications to work for the individual person. But there are multiple options out there for us to use to kind of step up and down until we find the right kind of cocktail for keeping everybody's symptoms under control. Now, unfortunately, the type or the class of medication is only one part of the story. We see, of course, we have these LAMAs and these LABAs and these steroids and all that kind of stuff, but we also see a variety of delivery devices. First and foremost, we see our traditional, what we call a metered dose inhaler, or a lot of times people will call it a puffer because when you squeeze it, nice little puff of medication comes out of there. This has been part of our clinical toolbox for a very long time. It's got this, this is a demonstration model that I have. Oops, sorry about that. This metal cylinder has your medication liquid in there. It goes down inside this boot where it fits into a little dispenser here. Can't see it real well, but it fits into this dispenser and allows the medication to come out in this misty spray. Again, works very well, but we don't often tell. One of the things I like to tell the people I see here in my clinic is that we, as a medical system, are really good at telling people to take drugs. We're not always so good at telling people how to take drugs, and so that's where I come in. That's where we're trying to do a better job at teaching these techniques. The other the second major type of inhaled medications are what we call the dry powder inhalers, and these are things that are really coming into play a lot more these days. A lot of the newer medications are coming out in this dry powder format, which does have some advantages over the liquid, in that it does tend to be, I guess, maybe a little bit more stable, and gives us a little bit more creativity with the dispenser types. Now we're seeing, like I said, a couple of different types. We've got the two biggest kinds where they range in complexity from this type of inhaler where everything is contained inside the capsule, and when you open it up it kind of rotates to the next strip, the next spot in the medication tape, and then you inhale from that, breaking up the powder and turning it into a mist where you can inhale it hopefully easily. The other kind of dry powder inhaler is this sort of thing where you have the capsule there we go. The capsule that goes into a little receptacle in here, and you close everything back down, you pierce it, and then you inhale from that. Obviously, there are some drawbacks with these kind of things. It's a little bit easier to store sometimes, but obviously it's kind of complex to open and close, and there's a lot of steps involved, and whenever you have a lot of steps, you introduce the potential for error, and whenever you have error, then you have the potential for not getting enough medication. Last but not least, with the powders, we have this very new type that is a breath actuated inhaler, they call it, where you open it up. It's a lot like this type where you open it up and it kind of gets everything loaded in, and you breathe the powder through there. Looks a lot like the metered dose inhaler, but it is a little bit blockier, and whether it's easy to use or not is kind of up to you. Again, if I can kind of get a little bit soapboxy here, we don't always do a great job at matching up the patient's needs or the person's needs with a particular device for a lot of reasons. Sometimes these things are only available on one particular device. Sometimes the payers will only pay for one certain device. So that's one of those things that we're really trying to work hard with to improve access with various devices and various types of medications. Because in order to most appropriately treat or manage COPD, we need to be able to match up the device with a person's abilities. And we'll get a little bit more about abilities in just a minute here. But I do want to cover the last type of inhaler, which is probably the newest on the market. This is what we call a soft mist inhaler, where it's made by one particular company. This particular device is called a Respimat inhaler, and things like Spiriva and steeltoe and stuff like that comes in here. They are very similar to the metered dose inhaler, but a little bit different in that where the metered dose inhaler actually has some propellant, like an old kind of any kind of spray can, like hairspray or bug spray or anything like that. Where those have a propellant to make that happen, this is actually more of a mechanical device. You twist this until it clicks, and that loads kind of a spring in here, and then you hit the trigger, and the spring recoils and kind of pushes this medication out in a slow mist. The advantage to this is it's a lot easier to inhale than powders. A lot of times the powders, you have to really be able to generate a lot of inspiration in order to make that turn from a powder into a mist a little bit better. And sometimes when you have the more severe cases of COPD, you're not able to do that. People aren't able to do that. And so this is a little bit easier to coordinate, a little bit easier to inhale, and a little bit more consistent medication delivery in a lot of people. The downside is because this is a spring, sometimes it's a little bit tough to get going over there, especially if you have a touch of arthritis in your fingers or anything like that. And sometimes if you do kind of an incomplete twist and it recoils back, you don't get that whole medication into your airways. It goes flying off into the ether, so to speak. So, a lot of these devices have pros and cons. A lot of them work very well together. A lot of them you need to match up with a person's individual abilities. Which takes us to the last main kind of inhaled medication, which is the famous, or perhaps infamous, nebulizer. This is the type of thing that a lot of people get, especially if you spent any time in the hospital for a COPD flare or anything like that. These are pretty much foolproof. You connect one end to a gas source, usually oxygen or sometimes medical air, and it blows through. You put the liquid medication in the little cup here, and the air blowing through here blows up at such a pressure and with such a design that it turns that into a mist, and everything just kind of goes, and you breathe in the mist. These are very good for people who are having a lot of trouble inhaling or who can't really coordinate that inhalation very well, because these are far less dependent on technique and ability than some of the inhalers are. This is a continuous flow type of thing, so you keep breathing in and out, you get medication. When you breathe in, when you're not breathing in, a lot of it will accumulate in here, some of it will blow out into the air and be a little bit wasted, but the ampules that the medications come in are designed to take that into account. So they're a little bit better for people who can't necessarily do that coordination. Most of the time that's when we're talking about when you're having a symptom flare or an exacerbation, as we often call it, and you can't, no matter how hard you try, you can't coordinate, you can't get all that stuff done. The downside to this is they take a lot longer than a meter dose inhaler or a dry powder inhaler for that matter, and they're obviously not quite as portable. There are certain portable nebulizers that run on batteries, but they tend to be a little bit more expensive and out of the reach of a lot of people. And so a lot of these drugs or a lot of these type of medications are kind of tethered into the home because you need to have your compressor hooked up to the wall outlet, and that generates your air source and all that kind of thing. In addition, there are certain classes of medications that aren't available in this in a nebulizer form. Most notably, the LAMAs, those long-acting controller muscarinic antagonists like Spiriva. There's no real equivalent to that kind of medication in a nebulizer. There are a couple of things in the pathway, in the pipeline, and we might be able to see them in the next few years. But for right now, that's if we're stuck using a nebulizer, that's a class of medications that's totally blocked out to us, and that is less than ideal, we'll say, for patient care. Rick and Tanya there mentioned a very good thing. When we have this kind of medication, or I'm not 100% sure if they were talking about this or about the Respimat, but it is sometimes hard to load the cartridge, and it looks like Donna has kind of experienced this the same way. You load the cartridge in there, bang it on the table to make sure it's in right. That can be very effective. I recently learned also that if you speak with your provider, they can write on your prescription to prepare your, particularly the Respimat, the pharmacists themselves, or wherever you're getting your medications, can prepare these for you and prime them and get them all ready to go, so that when you pick it up, it's ready to go and you don't have to worry about banging it on the table or anything like that, or even making sure you're pushing it in there hard enough. That was something that was fairly new to me, and so I don't think we're getting the word out to a lot of people with that. But if you are able to, or if you do have this prescribed and you're having trouble getting it ready to go, speak with your provider, whether it's your primary care or your pulmonologist, or whether it's your doctor, NP, PA, whoever it is, and ask them to write a prescription that tells the pharmacist to prepare this for you and get it ready. We've got a lot of good questions coming in. Again, we're going to cover a lot of these things as we get down toward the end here. I do want, so let's make sure that last week when we were doing this, that we had so many questions that some of them kind of scrolled back up so far. They kind of disappeared because of a Facebook quirk. Rick and Tanya, maybe this one here, getting the little powder or the little capsule into this device, maybe. But again, this can be tricky too, because you have a fairly small target. Getting it out of the blister pack and into this little thing, and then when you squeeze it, the little needles come out, oops, and pierce the capsule. And sometimes they don't necessarily pierce so good, and that can be trouble also. So before we get into some of the more specifics here, the last big thing I want to touch on, as you all heard me mention a little bit earlier, that we as a healthcare system are really good at telling people to take drugs, but not always so good at telling people how to take drugs. And that's where in my clinic, and this is something that I'm learning is becoming a little bit more widespread, which is fantastic. We need to start doing a better job at measuring inspiratory capacity when we're trying to tell people what kind of medication to take. Unfortunately, we see that particularly in primary care, we have put so many requirements on our providers that they don't always they're not always able to take the time to do appropriate teaching. So we're going to do that here. There are two main techniques that you're going to want to remember when you're taking your medications. The first type, when you're taking these meter dose inhalers, is most of the time we tell people we blow everything out, and then we take a very deep breath in as you're puffing the inhaler and getting it all into the lungs. And most people, when you say take a deep breath, they assume that you mean take a very fast deep breath to get everything down as far as it can possibly go. That's kind of human nature, but unfortunately that doesn't work very well. If you think about how your neck works, how your airways work, when you breathe in, everything kind of goes straight into your mouth, but then it has to make this very sharp turn to get down your throat and down your airways and into your lungs. Now think about if you're driving in a car and you come up to a curve and you're going too fast. You're probably going to spin out a little bit, hit that guardrail. If you happen to be cast in an action movie, you're going to fall off the cliff and your car's going to explode, and it's going to be a really bad day for everybody. Well, these molecules that come out of these inhalers work very similarly. They're already coming out pretty fast, so if you take a fast breath to accelerate all that stuff, they're going to just slam into the back of your throat. Hopefully they won't explode back there, but they're going to slam it back there, and they're not going to do any good to anybody because there aren't any of the chemical receptors back there to make this stuff work. So what we need to do, what we're trying to teach people these days, is to take a nice slow deep breath, just like you're about to yawn or sigh or something like that. You just want to go, Try to hold it at the end there. The textbook says 5 to 10 seconds. I know that can be tough when you have, again, some of that extended lung disease or the more severe lung disease. So hold it as long as you can and then blow everything out. And that's kind of the optimal technique for that. And I will say that Doreen's kind of skipping ahead to using a spacer here a little bit. We'll talk about that in just 1 minute. But that's tipping your head back. Thank you, Rick and Tanya. That can also be a very effective tool. Those are two very good things that we can do for improving technique and all that stuff. Now, the powders are a little bit different. And this is part of the reason I said that sometimes these aren't maybe as effective or as desirable in patients who have more severe levels of COPD, more severe airflow problems, because you need a certain amount you need to be able to suck in hard enough in order to activate the inhaler. It's kind of the opposite of the stuff that comes out of the metered dose inhaler, because this is already accelerated, but in the powder it's just sitting in there waiting for you to do all the work. And so each device has a slightly different activation speed, and that's why we have this thing that helps me measure whether people are able to actually use the device that we're trying to prescribe to them, or if they need to do something else. This particular device is called an in-check dial, and so if your provider doesn't have one of these, I strongly recommend you talk to them about getting one, because this has been an incredibly valuable tool for helping me figure out if people are actually able to use their medications. And the nice thing about this is it is adaptable, has different resistances to simulate the different inhalers on the market. And so when we're doing the dry powder inhaler, what we want to do is, as I said, kind of the opposite of the metered dose inhaler. We put it in our mouth and we really want to get that flow going so that we can break up the powder that usually comes in a little chunk. You can see it particularly well with this Neohaler device. When the powder gets broken out of the capsule, it kind of goes up against this little mesh here. And that, what we call, aerosolizes the powder and turns it into a form that you can actually inhale all the way down into your lungs. So we've got metered dose inhalers that are liquid. You want to breathe those slow, and that actually goes for the soft mist Respimat also. If it's a liquid, you go slow. If it's a powder, you go fast. Now, as I said, Doreen had kind of mentioned, skipped ahead a little bit, so gold star for her. We often also recommend people have what we call a spacer, or sometimes you'll hear them called a valved holding chamber. And these are very nice devices that there are a couple of different styles on the market. There are even some that have that are kind of like accordions that fold down flat, making them a little bit more portable. But regardless of the design and all that stuff, they have the same basic concept, where you put the inhaler in one end. Oops. You put your mouth on the other end, and you puff and you inhale. And these things, the way these things are designed to work is, they make it a little bit more easy to coordinate the puff and the inhalation, which can be tough because there's a lot of stuff going on when you're trying to think about your breathing and think about your focus on, well, am I squeezing it right? Am I squeezing it enough? Am I breathing too fast? Am I breathing too slow? Etc., etc. And in addition, they usually have at least a little valve in here. I think you can see probably a little bit better on this model. They have a little duckbill valve in there that kind of holds everything in suspension while it's waiting for you to inhale. These are great for that. Like I said, you can help with it helps with coordination. It helps get everything involved in there. The downside to these, there are two big ones. First of all, they're fairly not portable, we'll say. When we're having a rescue inhaler, particularly with the rescue stuff, we've got this that fits in a pocket very nicely, and then we try to throw this thing on top of it, and that's not it's a little more ungainly, doesn't always work as well. And so unfortunately, we see that these things oftentimes get thrown into a desk drawer or a junk drawer or something like that, or they just kind of collect dust for a while. And that's really unfortunate, because the other downside to these is a lot of payers, insurance companies, Medicaid, oftentimes even Medicare, won't pay for them. In their infinite wisdom, they have decided that the medication is essential, but the thing that helps you take the medication is not. And that is really unfortunate because these oftentimes are fairly expensive. And when you're already paying for inhalers, as has come up a couple of times here, when you're paying copays that are already $50, $60, sometimes even $300 for the full price of one of these things, for one of these inhalers, even another 30, 40, 50 bucks on top of that is going to be a major problem for a lot of people. So there are a couple of workarounds out there if you don't happen to have a spacer. First and foremost, the easiest thing, or the easiest and least expensive thing, is to do something we call the open mouth technique, which is basically a spacer without the spacer. You hold the spacer in front of your mouth, you open wide, and you... But there are a couple of problems with that too. Even though it does help all the molecules slow down and help you coordinate and get all that good stuff down there. A couple major problems. First of all, depending on how far you hold it away from your mouth, I felt it. I don't know how well you could see it, but a lot of that medication plume expands too fast and doesn't make it into your airways. In addition, if you're using a rescue inhaler and you're huffing and puffing because you're short of breath, you have to try to make sure you're lined up and making sure everything is angled right and the right distance and all that stuff while you're short of breath, while you're anxious, and while you're doing all that stuff. Not optimal. So they started marketing this little thingy, mini spacer called an inflow cone. Not nearly as technologically advanced as a true valved holding chamber, but it does work very well for kind of a brace, so to speak, or a target for the open mouth technique. Again, the inhaler goes on one end, the mouth goes on the other end, and voila. You've got good inhalation. You've got a little bit more of a buffer zone when you're trying to inhale. You've got nice aim. You've got nice spacing. It's very consistent. Works very well. These are much less expensive, on the order of $1 or $2 a piece, and so usually, if nothing else, you can get change out of the couch cushions or something like that to pick up one of these if your provider obtains them for you, which that's something we do here at the WMU School of Medicine. So I like to tell people, in best case, in the perfect world, you're going to use one of these every time you use a meter dose inhaler. In the real world, because we're able to hand these out, I recommend these. There are some other alternatives. A lot of times people will recommend using like a toilet paper tube or something like that. Again, better than nothing probably. The one thing I do usually recommend against is a lot of people like to say use some of this tubing from the end of your nebulizer, because this can sometimes look like a spacer. You can get the inhaler on one end, and you can kind of do that sort of thing. I don't usually recommend that because a lot of times the medication particles get caught up in the corrugations here, and you're not getting your optimal deposition. And when you're not getting your optimal deposition, you're cheating yourself in a couple of ways. First off, you're not getting the optimal dose of your medication, so you're not getting maximal treatment. And in addition to that, especially with rescue stuff, when you don't get that optimal use, you have to use more of it. And when the faster you use it, the sooner you have to buy another one, and the more money you have to spend. So it's really important to use the best technique possible so that you're getting your best treatment and you're using your healthcare dollars efficiently. So hopefully other clinicians out there we're slowly making inroads at teaching better technique and all that kind of stuff. But hopefully you can also use some of the techniques that you learned today in your own life without having to wait for your provider. I do have a couple of questions here as far as using inhalers. Rachel asks us, can we use inhalers past expiration dates? The official answer to that is no. Because from an ethical standpoint, I can't suggest that somebody use an inhaler past what has been designated as their expiration date. I will say that there is a fair bit of debate, particularly with inhalers, about what exactly that expiration date means. It's tricky because a lot of this stuff isn't necessarily based on 10 years worth of chemistry and analysis and all that, because it would be incredibly expensive to do that kind of study, and we still wouldn't necessarily get very good data out of it. So the manufacturers have to use kind of a best guess as to when the medication is going to lose effectiveness. Many of these molecules do degrade over time. Many, whether it's the medication itself, whether it's the propellant in a meter dose inhaler, whatever it is, they do lose some of their effectiveness over time, which means that they're not necessarily as effective or theoretically even as safe as to when they're within their expiration date. Some of it is probably an issue of scale also. I mean, if something expires on November 9th and you use it on November 10th, are you okay? Some of that is a risk-benefit analysis that only you can decide, depending on your individual situation. But that theory is out there. So that pretty much finishes off our regularly scheduled part. I'm going to scroll back a little bit here. We've got some more medication-specific questions that we're going to dive right into. Let's see. We've got when I can't breathe well, my doctor doesn't like to give prednisone, which really does help open up the lungs. Depressed and hopeless. Well, you are not alone in that feeling. We see that with many chronic diseases, particularly something that is as intrusive, invasive, affects every minute of your waking life and a lot of your sleeping life as COPD. It's very easy to feel hopeless because it's difficult to get somebody on the right management plan. And for a very long time, again, we haven't done a very good job at supporting a lot of the clinicians who are at the front lines of this stuff. The first thing I would say is please don't feel alone. Please realize that there are a lot of people in your shoes and we're walking that same path together, who are walking that same path together. I understand it also. It's very easy to feel hopeless. There are advances being made all the time. We're trying very hard to make these kind of teaching tools the standard of care for everyone across the country and even around the world. So I understand, I do understand, and I'm sorry that we as a healthcare system have let you down to this point. And I hope we can do a better job going forward. As far as not liking to give prednisone, that's again one of those things that it's an angel and a demon at the same time. It does work incredibly well with bringing down a lot of inflammation, but there are some pretty significant side effects, especially if you're on it for any kind of length of time, whether it's weight gain, whether it's mood changes, whether it's some of the other things that are out there. So every time somebody goes on prednisone or somebody takes prednisone or another similar steroid, it's this weighing the risks versus the benefits. And so I can understand where a lot of people are reluctant to do prednisone. If it's been effective for you in the past, that would be an indicator that you should probably get it again, but it can be an issue. And Diane also brings up a very good point. When you have an inhaled steroid or a medication that includes an inhaled steroid, and again, that's a lot of these are all steroids. These medications, Aerospan, Alvesco, Arnuity, Asmonex, 2 different kinds of Asmonex, Flovent, 2 different kinds there, Pulmicort, Qvar, or medications that contain a steroid like Advair, Breo, Dulera, Symbicort, Anoro, not Anoro. Advair, Breo, Dulera, Symbicort. It is very important to rinse your mouth out after you take your inhaler. And a lot of times we'll say even gargle and kind of a swish and spit whole situation. When that steroid builds up in the back of your throat, it can change the chemistry and allow this type of fungus to grow back there, which we call thrush, or it leads to these thrush symptoms. Which can be very painful, very dry, cracking, a lot of issues in the back of the throat there. So we do recommend that you rinse your mouth out every time you use your steroid inhaler. Unfortunately, inhalers are very expensive, and a lot of people do have trouble affording them. There are a couple of different strategies to deal with that. Sometimes your provider can provide some samples. That is an increasingly sketchy area these days. A lot of providers don't necessarily like taking on that risk or having that issue, and so that is not as prevalent as it once was. Each of the manufacturers also has what's called a patient assistance program, which you can find on their website, their various websites. And those can, based on income and based on other factors, can help you get access to some of those medications that are prescribed. They can be very effective, but again, they're kind of tricky sometimes. There's a lot of paperwork involved, a lot of time commitment involved, but they can be a valuable resource. In addition, some local governing units, like county health departments and that sort of thing, often do have other methods available to help offset those costs. There are a variety of other things out there. There are some websites that you can go to, and this is not an endorsement. This is simply a presentation of fact that you can order medications from other countries, and they do tend to be a little bit cheaper. There are certainly risks involved there as well, but that is the whole story there. As far as other methods of getting medications, like I said, I would try to speak with local health authorities or your provider to see if you can get any kind of sample or anything like that. N-acetylcystiene Ellipta, can it cause chest pains? Pretty much any medication that has any kind of stimulating effect, like N-acetylcystiene, which does have one of those beta long-acting, N-acetylcystiene, I'm getting ahead of myself here. N-acetylcystiene is a LAMA, like Spiriva and Tudorza. It could theoretically cause some chest pain. I don't think that's one of the more common symptoms. But if you're seeing that consistently whenever you take N-acetylcystiene, that is certainly cause for concern, and that would be something to let your provider know about right away, just so that they can see if there's anything else going on. Or sometimes it can be as simple as you have a little bit of pain when you're taking a deep breath, or it could be a symptom of something else going on. But if you're seeing it consistently, make sure you're checking with your provider about that and getting checked out as best you can. Let's see. Gave a Noro this week to try instead of Spiriva. Tried at worst pain in my eyes. Okay. A Noro is a combination medication that has a LAMA and a LABA, the long-acting muscarinic antagonist like Spiriva, and a long-acting albuterol type of drug. Pain in the eye is a little bit unusual. We do see sometimes with these antimuscarinic drugs, with these muscarinic antagonists, we do see sometimes there is a slightly increased risk of things like glaucoma, or they can increase the severity. Usually when we're talking about that, we're talking about muscarinic antagonist pills that you can take for various symptoms. But over time, we do see that there is a certain amount of risk involved with glaucoma, particularly with these meds. There's been some studies that have somewhat tied steroid use to that. And again, a lot of this stuff comes back to risk-benefit analysis. Are you at risk for that? Are how bad are your symptoms? Unfortunately, sometimes the poison, the cure can also be poison, just depending on the dose. And that's why it's important to report a lot of these signs to your provider. I am very big on having open lines of communication. I like people to be equal partners in their care, and to make sure that they have all the information they need to make appropriate decisions for themselves. And that involves weighing those risks. And if you feel that a risk isn't worth it, please don't hesitate to speak up and talk to your clinician and say, hey, I would like to try a different medication. I don't think this one is working, or I think the risks are too high. What else is out there? There are a variety of other meds on the market. There are a lot of things we haven't even talked about today yet. I do know I saw somebody, okay, there it is. Can NAC supplements help with COPD? And this is another one of those medications that doesn't fall into the inhaled category, but is sometimes used for these kind of symptoms. And what NAC is called N-acetylcystiene. And there have been some studies that have associated it with anti-inflammatory effects and clearing out mucus and a variety of other things. It has not yet been conclusive, just because it hasn't really been studied enough, at least in my opinion. But there is some evidence that it may help. This is one of those things that is available over the counter, but you do have to watch out for when things are available at like supplement stores and things like that. You do have to be a little bit concerned about purity and that sort of thing, because those controls aren't as strict. And I think that's also been kind of the issue with proving whether some of these work or not, is it's difficult to make sure that we're ensuring quality control for a lot of these medications. There's another medication out there called, the brand name is Daliresp, the generic name is Roflumilast. It is an anti-inflammatory drug, but it is not a steroid, and thus doesn't have those steroidal effects. But it has a whole other suite of effects, usually with gastrointestinal stuff. A lot of things that a lot of people have complained about, diarrhea and nausea and a lot of those things. But it has been somewhat effective in getting people to have fewer exacerbations and all that kind of stuff. All right, so yes, they could make you sick if they're too far out of date. That is absolutely possible. Angela, fellow professional there, devil's Tic Tacs. I like the sound of that. That's a good analogy. The med you love to hate. That is, a lot of these things are like that, unfortunately. They have so many positive aspects, and then they have the negative sides too, and it comes back to that risk-benefit. So let's, I'm still scrolling down here a little bit. Let's see, Bonnie. Hey, Bonnie, how you doing today? Bonnie is a longtime friend of COPD Navigator, so it's always nice to get her opinion on stuff. She's been walking a very exciting path. She's fortunate enough to live in an area with practitioners who are a little bit at the bleeding edge, so to speak, of a lot of this stuff. So Bonnie says, I had 2 Symbicort that were not full. Contacted the manufacturer and they made good, so if something is wrong with your prescribed inhaler, always reach out to the manufacturer. Yes, that's a very good point. Sometimes it is difficult to, a lot of these are now coming with dose counters and things like that. Sometimes you do get a little bit of a quirk in the manufacturing process and things aren't full. Drug companies oftentimes will work to make it right, because like any other company, they don't want to see the bad press either. And so they will oftentimes work to make sure that people are made whole with some of these things. If you do have a short inhaler, or one complaint I used to hear a lot when Spiriva was in the powder. Well, many people still do get it in the powder. Sometimes the little capsules with the Spiriva in it aren't full, or don't seem to have anything in them. Make sure you're reaching out to those manufacturers and letting them know what they see, because more often than not, if you're seeing it, somebody else is seeing it, and so you can help a lot of people out, and that's how we often trigger recalls and things like that. So, Rachel mentions having some Spiriva left from a doctor before they changed to Incruz. I think I'm going to finish it before I fill Incruz again. I feel as though I wasted my money when he changes mid-medicine. That's very fair. A lot of these things, it can be tricky to get the timing right. Hopefully, providers will understand that you want to finish out your course before you spend a lot of money on another med. I think that's entirely fair. One thing I like to do in my practice when we try to start somebody on a new medication, I like to see them in about a month. A lot of these medications take a good week, 2 weeks to kick in fully, especially the controllers. Things like Spiriva, usually we say at least 7 to 10 days. Sometimes it's up to 2 weeks before we get benefit to that. So I definitely like to see people after they've hit that what I call that therapeutic window. But it can be tough when we're taking into account a lot of the things that go into actually purchasing and obtaining the medication. So I think it's definitely fair to wait to start a new med until you finish what you've got. The problem with going back and forth is sometimes you lose that benefit. Like in this case, you might, as the Incruz tapers out, you're still having the Spiriva build up, and while they catch a lot of the same receptors, everybody's biochemistry is a little bit different. And what works well in one person, one med may work really well in one person and not do a thing for somebody else. And so you do kind of open yourself up to a little bit of that risk there, where your symptoms aren't going to be as well controlled during that transition period. So just be mindful of that as you're contemplating what kind of strategy changes you're taking. Can vitamin C help with breathing? Usually we look at vitamin C as being more of an immune supplement. It doesn't always help with breathing. We have found that people with low levels of vitamin D and vitamin A seem to be a little bit higher risk of having exacerbations. It's not necessarily a thing where the more you take, the safer you are, but you do want to make sure that you're within the normal ranges of vitamin A and vitamin D, so that if you do have any issues with the exacerbations, we try to keep those as mild as possible. Vitamin C, maybe not so much. Drinking water to thin out mucus, that is absolutely a good tip. Making sure you stay hydrated if you have problems with thick mucus before you even hit some of those medications that are designed to thin that stuff out. The frontline thing is definitely staying hydrated. Drinking plenty of fluids, especially water. Trying to avoid some of the things that may dehydrate you, like caffeine, alcohol, that sort of thing. Water is a fantastic thing to do, and that will help thin out some of that mucus in many cases, and allow it to be coughed out a little bit better. Rachel, Dalares was not so good. Again, this is one of those things where just depending on the individual's biochemistry, your individual makeup and all that kind of thing, some things work great, some things don't work. And that's why sometimes it's so hard to come up with a good treatment plan, because we can say, we can look at our medication recommendations and say, okay, we want to start everybody on a LAMA. Well, okay, which one do we start with? Do we start with Spiriva? If that doesn't work, do we escalate care? Do we go sideways and try another medication? And sometimes it takes it takes a lot of trial and error before we find what works for the individual person. One of the things that is coming up on World COPD Day next week is a conference in Philadelphia, sponsored by Temple University, featuring the great Dr. Gerald Kreiner and a lot of other pulmonologists from around the world. And I noticed this year they're having several different pro-con things going out there. One of them is individualized medicine, personalized medicine, kind of the best practice for a lot of people. In my opinion, that's definitely so, because everybody is going to respond a little bit differently to different meds. So it's important to try to find the right thing to do. Of course, the issue with that is, as we're trying these different things and we're trying to get everybody managed right, you, the person taking the medications, might still be suffering. And we certainly don't like to see that any more than you do. So it's difficult to find that balance between taking time to find the right thing and making sure we're doing everything we can to treat you right now. Let's see. Kathy mentions went off Brio in March with pulmonologists. Okay, which of course, absolutely, we want to make sure your clinicians are aware of any changes. Didn't want to continue with a steroid-based inhaler. So far, so good. And again, we're seeing a lot of that. Much of what we have originally done with COPD again came out of the asthma world, where arguably inflammation is a little bit more of an issue. We do see a lot of inflammation with COPD, but sometimes it's stuff that, depending on exactly your form of COPD, your case of COPD, your phenotype of COPD, sometimes we don't necessarily see a lot of inflammation, and so we're throwing these steroids at people, potentially increasing their risk for side effects without a lot of benefit. So that's why the latest GOLD recommendations have said that sometimes if you have been taking a steroid and haven't really noticed a change, sometimes it's okay to back off and see if anything gets worse. So excellent combination. Let's see, using steeltoe about a test. Do you think there's a big difference between that and others? Was on a Noro before. The Noro seemed to hurt after taking it. It's, again, this is one of those things where it's going to be very individualized. Most people are going to see some benefit from a class of medication. Like I said, if you take Spiriva, you might see benefit from Tudorza or Incruz. It might not be quite as much, or it might be more, just depending on how the drug interacts with your body. Do I think there's a big difference between steeltoe and other similar medications? Steeltoe is one of the few meds that is the combination of the LAMA and the LABA together. It's right here on the chart here. So our other options here are Noro and Ultibron, which is not in super widespread use just yet. And it's difficult to compare apples to apples because those other two are powders, and the steeltoe comes in that soft mist Respimat deal, this thing. And so there's a lot of what I consider to be confounding factors about whether you're inhaling properly, the technique, and all that stuff. Usually studies are pretty good at controlling for a lot of that stuff, but it's difficult to just go at this scale to go head to head and say one is better than the other. It's going to very much depend on your inspiratory capacity and your individual case, your individual symptoms and type of COPD damage. Dalaresp, there's not really much else on the market that does the same thing. That's a fairly unique medication right now. So unfortunately, if that doesn't work, then there's not really an alternative there. As far as boosting your immune system goes, making sure the biggest thing, especially as we get into the winter here, is make sure you're up on your vaccinations. Flu shots are great. Even there's, oddly enough, a lot of controversy about flu shots right now, and while it may be true that they're not always 100% effective, generally speaking, even if you get the flu after having a flu shot, it's going to be less severe than if you just got the flu. So we definitely recommend everybody who has COPD get those vaccinations, including the now series of pneumonia vaccines, just depending on what you've had before. The CDC has particular guidelines that your provider should be aware of to make sure that you're getting the appropriate dosages and the 13 and the 23 valent or component vaccines, making sure you're getting them in the right order and at the right time. So definitely make sure that you speak to your provider about that. Beyond that, doing hand washing, that can help slow down disease transfer. Wearing a mask if you're going to around a lot of people. As far as boosting your immune system itself, make sure you're getting plenty of rest, make sure you're staying hydrated, making sure that you're doing all the normal things that your mom probably told you to stay healthy. Those are often the best ways to keep that immune system healthy and functioning normally. Unfortunately, I can't really get in a lot about cannabis right now because it's controversial from a legal standpoint, so that's a topic that there are groups on Facebook that do address that, but that's not something that I can really take the time to talk about right now. Pulmonologist said the only one he's ever seen that has gone from lung function of 20 go back up to 38. And that is fantastic. A lot of these medications do try to improve that. I try not to look at lung function as one big percentage. There are a lot of things that are involved with lung function. A lot of times when a provider says your lung function has improved, they're talking about one specific measure called FEV1, which is the amount of air you can blow out in 1 second when you blow out forcefully. Like, excuse me, when you have an obstructive lung disease like emphysema, chronic bronchitis, any of the COPD diseases, that is slowed. That is because of, whether it's because of mucus or whether it's because of airway issues, that is slowed down. And a lot of these medications absolutely work to improve that by improving the muscle status in there, bringing down inflammation, all that kind of stuff. There is going to be some variation from year to year and even from day to day a lot of times in that lung function, but from an FEV1 change of 20% of the predicted value to 38% of the predicted value is pretty significant, and that means that you're probably on a pretty good course right now. Again, it's sometimes difficult. We can say that, but we have also seen that in the individual, that degree of airway obstruction, that FEV1, doesn't always correlate very well with how a person feels, what we call their symptom burden or their exercise tolerance or all that kind of stuff. And so sometimes it's a little bit misleading when we say, hey, you're getting better, and you certainly don't feel any better. So I try to be mindful of that, but that is good, and that means that your plan is hopefully optimized. Again, talking to your med, or talking to your doctor or your provider about getting a med or a different med that's covered, or finding some discounts, taking some Dalaresp, excellent. We've got a couple minutes here. Looks like we got a couple last questions to get in here. Gone from stage 1 to very severe stage 4 in 6 years' time, even with quitting smoking immediately upon diagnosis. Why do some people progress slow and some people progress fast? That is kind of the golden question in COPD right now, and actually a subject of some controversy. We have traditionally looked at people with this staging guideline, again, based on how badly or how severely your FEV1 is impaired, based on what we would expect for somebody of your age, your gender, your height, and your ethnicity. Obviously, everybody, different heights, has different sized lungs. Men and women have different sized lungs, so on and so forth. So we try to compare as apples to apples as possible, and that's where we get these percentages from. These are percentage of what we would expect to see of somebody of your demographic makeup. And so traditionally we've looked at how severe a person's COPD was based on that degree of obstruction. And so that's where we get from stage 1 to stage 4. More recently, as research has continued, we've seen that that isn't necessarily the best way to evaluate somebody. It's much more important to look at a person's exercise or their symptom burden, where we use a test like the COPD assessment test to figure out how much your symptoms are impacting your life. And we look at your risk for another exacerbation. We look at your risk by looking at your history. If you've had a couple of exacerbations, the more exacerbations you've had, the more, especially in the last 12 months, the more likely you are to have another one. And so that's kind of where we're looking at severity now. As far as to the question of why do some people progress slow and some people progress fast, there are a lot of combinations there. There's genetics. We're learning that more and more about the genetics of COPD as we look at some of the wide-scale projects like COPD Gene that are out there. We look at environmental factors. We look at medication optimization. We're seeing that the earlier we can intervene and get people on a good treatment plan, the better off they usually are down the line. And we're looking at seeing whether that's a true progression or not, because we see that we have some people who are stage 2, which is maybe moderate COPD, who are on oxygen 24 hours a day. And we've got people who are very severe, the old stage 4, who are literally running marathons. We've got, there's a couple of people out there who are still very athletic, even though they have this very severe airway obstruction. And so we're really trying to get a better handle on how we're defining mild, moderate, severe, very severe. We're even seeing there's this idea of what we call PRISM, or that which stands for Preserved Ratio Impaired Spirometry, where you don't necessarily fall under the strict clinical definition of COPD, but you have symptoms, you have risk factors, you have all the classic signs of COPD without that spirometry thing. So we're trying to figure out, is that a different disease altogether, or are we just not doing a good job at identifying what is an airway obstruction? So unfortunately, it's a very long way of saying it's a very complicated issue. Why do some people progress faster than others? It's very similar to why are some people taller than others? Why do some people grow faster than others? Why do some people not get COPD at all if they, even though they smoke 3 packs a day? It's a very difficult question, and unfortunately we have not historically done enough research to answer that question. But again, that is changing as part of things like the National Action Plan and those initiatives. We're starting to get some understanding of why those are. So ask me again in 5 years. Pam mentions, my insurance will no longer cover any of the Respimat, so I can no longer use steeltoe. Now currently on a Noro. I really like a Noro. A Noro and the Astral 150 have made a big difference in health. That is fantastic. For those who maybe aren't familiar with some of these things, the Astral is a non-invasive ventilator. It kind of helps take some of the respiratory effort off of people. One thing that I will point out is, in Pam's case, it's kind of lucky that she actually prefers the newer medication. If your payer decides that they're not going to keep this particular medication on formulary or their list of meds that they pay for. The vast majority of them do have a process called a formulary exception, where your provider can fill out, unfortunately it's a boatload of paperwork, but they can fill out some paperwork, and if they have clinical justification, which we do for a lot of these medications, they can induce, it's like an appeal process. They can appeal the decision, the non-formulary decision, and get you that medication back. So if you are on a med, they take it away, your lung function goes down, you start having more exacerbations, all that kind of stuff. Talk to your provider and ask them about a formulary exception for your payer to try to get that back under control. We had to do that a few times here at our clinic, and like I said, it is a boatload of paperwork, but it can be effective. So sometimes it just takes rattling some cages. Quitting smoking is an excellent thing for lung function. I don't want to gloss over that at all, but we are getting a little bit cramped for time here. But yes, arguably the two biggest things you can do for your lung health are quit smoking and get some exercise. You know, a lot of times it seems counterintuitive when it's difficult to, when you get short of breath walking across the room or to the bathroom or to check your mail. It seems kind of strange when we tell you to jump on a treadmill for a while, but activity and building up that endurance, again, that can be one of the biggest things you can do for your lung health, and that's why it's so important to improve access to things like pulmonary rehab and those kind of services. Exercise is critical. Exercise is also sleep. Sleep is also very critical to doing a lot of that stuff. I see Diana coming up here. I'm wondering if maybe I'm misinterpreting what you're saying a little bit. I personally think staying hydrated does help keep a lot of illness away. Most people tend to run a little bit on the dehydrated side, a little bit on the fatigue side, and a lot of that stuff, especially when you have chronic disease to deal with, which makes it all that important to try to keep up with that sort of thing, and hopefully keep that stuff together. Never given a stage. That's excellent. Like I said, I personally am trying to move away from some of the stages and into these groups. The Gold uses A, B, C, D groups instead of stages because staging, it can be very tricky. What can we do to control exacerbations? Well, the best thing is to make sure that you're on a good management plan, whether that's exercise, nutrition, medications. Make sure you're sticking with it and you're letting your clinicians know, your providers know early on if anything is changing or if anything is not working properly, and open lines of communication. Trying to avoid illness, making sure you're up on those vaccinations and staying away from things, all that kind of stuff. So we're going to take a couple more questions here. I did have a question from our group, from COPD Navigator, asking about what my opinion of theophylline is. Why is it not in an inhaler? It's a very old medication. Yes, it is. In the just about 12 years I've been a respiratory therapist, I've seen about one person who's on theophylline. It used to be a very frontline medication. Theophylline is a chemical that is very similar to things like caffeine, and as such, it has a very narrow therapeutic range. It's very easy to get too much, and it's also very easy to not get enough because you're worried about getting too much. And so, in my personal opinion, and in a lot of the studies, there are a lot of things that work just as well, have the same kind of bronchodilation capacity, but are a little bit more safe, a little bit safer to use, a little bit wider therapeutic band there, where they're not going to put you at as much risk of accelerated heart rate, raising your blood pressure, all those cardiac side effects. And so my opinion of theophylline is not great. It was great for its time, but I think there are better things now. So last couple of things. Jim and Mary, I always want to make sure to bring them in there, some of our great COPD advocates. Oversimplification, but generally the fewer the exacerbations, the slower the advance of the disease. Absolutely. We threw a slide up last week for our COPD basics presentation that kind of put this stuff, every time, a lot of times people look at it as stair steps. Every time you have an exacerbation, you kind of drop a step, and you never quite get all of that back. You might bump up a little bit, but usually it's pretty level. Then you have another exacerbation and you drop again. And of course, the lower you are, the more likely you are to have a future exacerbation. And that's why we why we try to take into account your history of exacerbations when we're talking about severity and all that stuff. So let's see. The last question we're gonna take today. This is a good one. Judy mentioned she got intubated about 3 years ago, where they have to put the breathing tube down your throat and put you on a mechanical ventilator to help with your work of breathing, whether you're either not protecting your airway very well or whether you're just too tired to move that air in and out and the carbon dioxide builds up, all that stuff. They said I couldn't be intubated again, that I wouldn't make it. Is that true? Again, it comes down to some of the risk-benefit stuff. and it depends on what the underlying reason is for why you're being intubated. A lot of people get concerned about that. Maybe you have to have a knee replacement or something like that. And generally speaking, well, when you have that, you need to be put on a ventilator because you're going to need to be fully sedated for that. Something like that, you're probably more likely to be able to be what we call liberated from the ventilator after the procedure, because your lungs are relative for them, they're kind of at their baseline. They're relatively stable. If you were to have another very severe exacerbation where you got sent to the hospital and they wanted to put you on a ventilator, it would be probably more difficult now, after having been on there once, to get you back off of it. And that's why these days there's a big push for what we call non-invasive ventilation, where we use a mask, a tight-fitting mask, to try to get the air in and out, rather than doing the breathing tube, which has its own set of complications. So I would hesitate to say that you wouldn't make it, but anytime you have that, it is definitely a risk, and it is definitely a potential risk for the future. So with that, we're going to wrap things up a little bit. Welcome in a couple of people who came in very late. Not trying to shame anybody or anything like that. These times don't always work great for everybody. These are good times for live, but I would like to point out that these are also available recorded. These will be available through the Foundation's website, and if you go to YouTube, you can, I've got last week's up already, plus some of our more historic ones from our group here. These are recorded and stored for posterity. So if you weren't able to join us today, definitely go on YouTube and search for COPD Navigator and check us out then. You can also check us out next week at 1 p.m. Eastern Time, where we're going to be talking about, what's our topic for next week? Next week, our topic name is heavy breathing, which is, we're trying to be a little bit clever here. We're going to talk about breathing techniques, coughing techniques, and some of the other things that we can use, some of the little tools we can use to help clear your airways for those of you who may have some trouble with phlegm and mucus buildup in your lungs. We're also going to talk about breathing techniques that you can use when you're short of breath and you either don't want to or can't use rescue medication to try to get that breathing back under control. So that'll be next week, 1 o'clock Eastern Time. In the meantime, please feel free to, of course, keep the conversation going here on the COPD Foundation's website. Another, again, a very gracious thank you for them providing this venue for these events. You can also come join us at our group here on Facebook, which we'll put a link up just a moment when I can type. It's facebook.com/group/COPD Navigator. We've got a great community of healthcare professionals and people walking the walk right now who are very willing to share their experience with everybody, whether you're newly diagnosed, whether you've been dealing with it for a long time. We love to hear all those perspectives and help out as many people as we can. So until next week, I hope you take care of yourselves, hope you take care of each other, hope you got your batteries and your smoke detector changed with the change from daylight savings time to regular time. Hope everybody has a fantastic weekend, and I'll see you next week. Take care.